It's an honor for me to present my innovation together with Dr. Kenneth Egol and Professor Vaida Glatt at the Academy meeting.
As far as disclosure, I want you all to know that I am not an investor in this company. I do not receive any royalties. Ilya hasn't even ever bought me a cup of coffee. You know, I've been doing this for over 30 years, and I prescribe people weight-bearing restrictions. And they ask me, how do you do that? And I often tell them, I don't know. Usually what we do is say, well, go step on a bathroom scale, and you can kind of figure out how much 30 pounds is or 40 pounds is, and you know, remember that feeling and see how you do. And I was happy to get my patients involved. We did an IRB-approved prospective trial, and we gave all of the patients, we did this, it's a pilot study, we did with 20 patients, and they all had lower extremity fractures, pilons, ankles, plateaus, distal femurs, and they were randomized to either receiving real-time feedback or not. In other words, the device would give them the feedback as to how they were doing on their weight bearing. And what we did was we had people come in the office, and we installed the crutch tips for them to make it easier. We got them on the app, and then we had them all step on a scale in the office to show them what the prescribed weight bearing was. So for a person had 30 pounds, we'd show them what partial 30 pounds felt like, and we said, try to remember that and go with that. And then we kept the data on all of the patients, and basically what we found anyway, was that patients receiving the real-time feedback had a 3 times greater adherence to the weight-bearing protocol that we prescribed, which makes sense, right? Because it's a learning type thing, and when people get feedback for anything, they can do a better job of improving their performance. I was actually very surprised in New York City, kind of a tech-heavy city. People were even my older patients were very, very interested in the technology of this. They thought it was really cool, and they felt that, they were taking part in their own care by doing this, which I thought was pretty interesting. We had excellent usability scores. They felt that it was very easy to use. High patient satisfaction rating, 9.6 out of 10. And there were no safety issues with the use of the device.
It takes some time to figure it out, to almost understand it mentally, what you have to do and how you have to walk. But the device itself makes it so much easier, because otherwise I honestly don't think you'd even know at all how much you're supposed to actually apply.
If you are on crutches and your recommended recovery involves some percentage weight bearing, I think there is no other way to understand that than to have these tips.
Yeah, so, we prescribe these weight bearing precautions for a number of reasons. Number one, we want to protect the patient, right? If we're fixing a periarticular fracture with hardware, we want to make sure there's enough healing before we allow for full weight bearing, so that we don't overload the construct and have an early failure. But we want to load the bone, and we want the joint to be active, right? We want the bone to see load to enhance healing, and we want the joint to be active to enhance cartilage nutrition and restore mobility. Now, what are these findings mean clinically? Well, first, this biofeedback that we're able to give the patients really allowed us to give patients a tangible target that they could hang their hat on, right? And we know that, secondly, adherence improved. We know the surgeons are going to feel more comfortable about advancing people. If we know that the patient is following our prescription, after 4 weeks, we see that they're very compliant. We can advance them very slowly, and we can follow them. You're able to monitor the patient with this as well. And the third objective was, as I mentioned, the balance between healing and hardware protection, right? We all know that there's a race between bone healing and hardware failure. And I think this helps us. Once we're done operating on the patient, we have x-rays every 6 weeks or so. That's the only way we know what's going on. But I think this gives us another valuable insight into how the patient recovery is going. So, again, these are the things I mentioned: precise adherence, prescribing accelerated bone healing, and risk reduction in hardware failure. In conclusion, I feel that these crutch tips are not only effective, but they're safe, they're usable, and I think they can help us in our clinical practice with patients to have a very standardized approach to the way we prescribe weight bearing after fracture surgery in the lower extremity. So while these prove very safe and reliable for home rehabilitation, we have to look at other ways and other ways that this is going to help our patients. And adherence and protection is only part of the story. The more important thing, or just as important thing, is how controlled weight bearing and how loading the bone aids in healing and recovery. And with that, I'm going to invite Professor Vaida Glatt to come and discuss the biomechanical principles underlying controlled loading and how manipulating the mechanical environment can shape biological outcomes in fracture healing. So, welcome, Dr. Glatt.
Good afternoon, everyone. So yes, my name is Vaida Glatt. I'll change the slide. I'm Director of Research at UT Health San Antonio, and for the past 20 years, I've been doing research in orthopedics and specifically mechanical environment and fracture healing. So I will try to explain it to you and show you how important it is, especially this initial loading and specifically through load bearing, because implants is not everything, right? So the key actually to successful bone healing relies on the synergy between biology and mechanical environment. And interfragmentary movement, as you can see here, between basically the loading between those fracture fragments, it's very important, and actually it was determined the most important mechanical factor. And that is actually determined by fixation stiffness and of course load bearing. Oops, too fast. And if its fixation is actually too rigid, we can get it with a reduction of the plate, the bone would heal through primary bone healing. But also secondary bone healing, if we have more bit flexible fixation, which is normally happens if you have an implant of like intramedullary nail. And of course, tissues depending on that loading, and that depends on weight bearing because the implant is not everything. If the patient sits in a wheelchair, no matter how good your fixation is, it would never heal, because bone is a dynamic tissue and needs to be loaded continuously in order towards that progression of bone healing. And of course, if the implant fixation, also very important, if it's too flexible or too rigid, the healing might fail, becoming too delayed or non-union or fracture. So here, just to somewhat summarize it and show you that there is, depending on the tissues we want to form, cartilage, bovine bone, or that lamella bone, there's a specific strain between the tissues that needs to be applied, and we can play that based on that mechanical environment. Of course, first implant comes, but also the patient has to be loading in that weight. That's where that weight bearing comes in. And how can we control it? So this is the added benefit, not only compliance, but we can actually calculate precise loading conditions for any specific patient to basically personalize it. And then the patient safely applies that loading. So here's how it works. In order to bone to start healing, you need to load initially, because if you miss that period within 3 to 6 weeks, it never heals, because it just passes that period, because this is how the body is designed to heal. So once it builds up that tissue, then we can relax, and then the Wolff's law plays in, and you can just keep loading. So, and that was my initial, I call it reverse dynamization, which is purely works from the implant point of view. But loading in terms of weight bearing is very important as well, and I'll show you how. So here's what we do, and we did a couple of studies now. We take a CT scan after implantation of the implant, whatever it is, like plate, nail. In this case, let's say it was an intramedullary nail at the tibial midshaft fracture. We can calculate specific loading conditions to make sure that implant does not fail, but also promotes that natural, healthy healing response. So we want the most rapid, optimized healing based on that loading condition. And let's say we figure out, and of course the patient's weight bearing plays a huge role. So then we prescribe this load bearing based on this FEA modeling, and that's what it is. We can prescribe it in the app. Now that the patient should comply, patient follows the prescription. Let's say we said initially start loading 3 to 50%, and we can remotely monitor, make sure that patient is compliant to it. And we already have 3 parallel randomized multicenter trials, of course not including here in the United States, but this is all in Ukraine. As you know, there's a war, and of course we have lots of patients there that actually need this stuff. And as you can see, we have different extraarticular, proximal tibia fractures. We have 16 clinic centers that are involved. We have 31 orthopedic surgeons that are doing this stuff. And so far we started clinical trials, and we have 10 patients enrolled out of 90 that we would like to demonstrate this efficacy, not only in terms of compliance, but also that healing response in when you have that optimized healing. And here I would like to share one of those cases where we had a patient that actually was prescribed weight bearing as tolerated. And some of you orthopedic surgeons, you do that quite often, because if you had a simple tibia fracture, you just tell the patient just load this. But some of these patients are afraid to load, because if they feel a little bit of pain, they would not be walking. And here's what we found. As you can see here in these fractures, I don't think if I have a highlighter, but as you can see, there's very little response, because this patient had a little bit pain and she refused to walk. So she was kind of wheelchair bound a little bit initially. And as you can see here, there's very little bone healing. So that's how important it is, right? So you cannot tell patients just, oh, weight bearing is tolerated. You should not be telling your patients that. You should making them walk, because bone is dynamic tissue, and if you don't load it, it would never heal. On the other side, you have this patient where we calculated precise weight bearing as tolerated. We wanted to build the maximum callus formation, which is about 8 to 12%, 8 to 10% of established strain that we can displace, not to damage that bone healing. And as you can see here, this patient built up amazing callus formation, had complete healing by 12 weeks. So those are the differences you can observe when you have actually proper weight bearing for patients, and not delayed but early on, because that's the most important. If you miss that window, it's probably going to delay bone healing. Maybe not become a non-union, but that delay in bone healing. Also, what we found based on that compliance was, because we could collect the data, we saw that the patient who was prescribed weight bearing as tolerated only made 20,000 steps in the same amount of 12 weeks that the other patient made 100,000 steps. So, and that you can clearly see it in the terms of how well one patient healed and the other one did not. And actually, if you see it here, if this patient would keep loading, the patient A who was prescribed weight bearing as tolerated, they might have a delay in non-heal, but it could become a non-union, and that, which is of course none of the orthopedic surgeons who have treated those patients want to see that.